Good afternoon, everyone. I'm Wendy Tsai, and I'm here with the Audacious Inquiry team, or AI. We're really pleased to welcome you to today's webinar hosted by AI to explore mapping a road to success with hospital ADT notifications as part of your organization's care coordination and quality goals. Now in its 11th year of operations, AI is a health information technology and policy company that's based in Baltimore, Maryland. From our work in the enterprise IT trenches and with dozens of teams, technical boots on the ground with customers, we see today more than ever that providers, hospitals, accountable care organizations, health plans, and Medicaid MCOs can gain valuable and actionable near real-time information when patients are admitted or discharged from hospitals. That's by using ADT-based notifications. We'd ask you to reflect and ask yourselves in recent times, how many of you have heard about or experienced firsthand a connected care and quality initiative that enhances coordination capabilities and also helps care coordinators and doctors manage the health of individuals and populations? Today our webinar will touch on observations about the value of ADT-based notifications that AI has gleaned from over a decade of experience in working in the trenches of health information exchange. We'll demo our ADT notifications platform, which is called ENS. You'll see firsthand that this is a connected care service and that the platform can easily fit into the strategic care management aims of health organizations. So that means things like reducing readmissions, improving outcomes for high-risk populations, and improving patient satisfaction. I'm pleased now to introduce our presenters. Today we have Scott Atzel, who is a partner at Audacious Inquiry, and he's joined by Rob Forst, who is a principal at AI. Both are part of AI's executive leadership and have worked with clients that run the gamut of our healthcare community and industry, from hospitals to statewide HIEs to some of the largest integrated or regional health systems and pioneer ACOs like Johns Hopkins Medicine. Scott will start us off, and we're excited for you to hear him, as he also serves as the program director for the state of Maryland's HIE, which is known as CRISP. He's also led deployment of infrastructure and systems for data sharing between several statewide HIEs that set a nationwide standard for notification services. Now, during the webinar, we welcome your questions. Up on the menu bar of GoToWebinar, you'll see a question mark. Go ahead and click there and send us your written questions, and we have time carved out to discuss these at the end. Thank you very much, and now on to our program. Please take it away, Scott.
Thanks, Wendy. So thanks for joining, everybody. I saw some of the names of folks who are joining and saw some of our buddies are on the line from Florida. So thank you all for joining. Aaron, Heidi, great to have you. And we'll talk a little bit about a number of our partners at health information exchanges around the country. Just to give you a little sense of AI and the work we do, we thought we'd reference just a few customers so you can get a sense for who we are. We've got health information exchange organizations. Some of these folks may look familiar to you. Philadelphia, there's HSX. I mentioned Heidi and Aaron from Florida and ACA down there. I work very closely with CRISP in Maryland. We've obviously got our partners in Delaware and Utah. We also do work with large health systems and the federal government as well, both on software development and product deployment, but information policy consulting as well. And that combination of work has proved really important and valuable in helping us plot a path forward on how we can leverage ADTs and develop a notification service. So as we go through the slides today, Rob and I are going to be speaking mostly at the high level about the value of notification services. We obviously have a notification service, but really what we're trying to provide is information and insight to help you either deploy or assess solutions and things you should be considering as you look to move down this path on deploying a notification service. So many of you may be hearing kind of broadly in the space we all work in about, and increasingly hearing about the value of ADTs, and we're going to get really kind of deep into what ADTs are and what they look like and how they can be used. But we just included a quote here from a guy a lot of us know, Farzad, kind of highlighting the value of ADTs and how much you can do with them. And as you'll see as we go through these slides, the core intent here is to show that with really basic content, you can accomplish some pretty powerful services with relatively low barriers to entry, both technically, financially, and operationally. So at the most fundamental level, we're talking about the power of basic data, and we'll talk a little bit about the power of some relatively basic infrastructure through which that data can flow. For those of you that aren't familiar, ADTs are a type of HL7 message, stands for admission, discharge, transfer data. That's actually, I learned recently, not an acronym. That's called an initialism. I don't know if everyone knew that. That's a little nugget you can take away. If it doesn't spell a word, it's not technically an acronym. So that one's a freebie for everyone. Go use that with folks, and they'll love you. So ADTs are already generated at hospitals during registration processes, during admission, during discharge. They're messages that are created from registration system and triggered throughout different hospital information systems. So as the patient's being registered in an ER, for example, and that registrar is capturing certain demographic data and key content about their visit, when they click next at a certain part in their workflow, that message triggers outbound. So there's no additional workflow or screen disruption that has to occur to enable ADTs to start flowing. As the second bullet points out, they're not that complicated. When you talk about HL7 interfacing, sometimes it's a black box, and you see these big numbers associated with getting a feed built. Well, some feeds, like a lab feed, for example, can be more complicated than others. The ADTs are really basic. One of our big insights when we started getting into this early on is we were familiar with certain other vendors charging relatively exorbitant fees to build an outbound ADT. And when Rob and I first sat behind one of our interface engineers and watched the process to build one, it blew us away just how quickly that first map can get developed. And it was instructive to us that that's not the place to be investing. Those are our capabilities that are relatively basic to get deployed and stood up. So it shouldn't be complicated. It shouldn't be expensive to build outbound ADTs. And lastly, there is important clinical and care coordination value to ADTs in and of themselves. When we first started getting into health information exchange, ADTs were typically used as a way to build out a master patient index, the ability to create a unique ID by seeing a patient that went, an ADT for a patient that went to 2 different facilities and linking them together. So they were kind of treated as a step towards health information exchange rather than a valuable data type for health information exchange in and of itself. And once we started recognizing that, we made a lot of progress quickly, and we'll talk about that in more depth. So just to break down an ADT, sometimes we talk about these things without actually ever having seen one. So this is an HL7 V2 version 2 ADT message. You can see, and we've just kind of pulled some components out just to kind of illustrate a point here. But you can see different segments and fields within the ADT. So you see MSH, message header, PID is patient ID. And within the message header, you can see ADT AO3. And so that's a specific type of ADT message. And AO3 is a discharge message. And AO1 is an admit message. And so there's dozens and dozens of ADT message types that represent different events occurring. As you move down into the PID segment, that's a really valuable segment for the service and the approaches we're going to talk about. It contains the patient demographic data that is used for patient identity management and matching. As you move down, you can see different segments. IN1, insurance segment. We're actually going to talk about the flaw in that segment, and Rob's going to kind of point this out as we go. There are other segments, such as the provider of record, which also have key challenges with them. So kind of stepping back at why we developed a solution that we've deployed with many of our partners was really based on, as I said, the realization that in Maryland, there was a lot of ADT connectivity already flowing through the health information exchange there, but not being used for much by way of an actual service. It was being used to build out, again, that kind of cross-facility unique patient identity, then kind of building towards other services like query. We had a few providers approach us and ask us about enabling a notification service, and when we evaluated how that would have been done with the current technology in place, it was a lot like a lab result. The ADT would flow, and the HIE technology it hit would look at the provider of record segment, and then it would match that up to a provider directory operated by the HIE and trigger that event outbound. And that had some fundamental flaws in it, primarily based on that workflow, that attribution process, essentially the patient attributing themselves to a provider at the point of registration. So if you just kind of step back and think through that, the way the notification would effectively route to the right place was premised on the patient having and accurately communicating who their doctor is to the registrar, who then had that doctor in a local provider directory there at the hospital, and some communication pathway either directly or through some sort of health information exchange like technology to actually notify them. And when we talked to some large health systems, we found that that was really only effectively occurring within a reasonable time frame about 20% of the time. So an exceedingly low hit rate for effectively getting notifications out the door. And so we kind of turned this around. And so well, what if you go to the practices in the community and ask them to attribute themselves to their patients? So instead of patient attributing themselves to provider at the point of care, provider attributing themselves to their patients in advance. And there are important policy frameworks that we support our customers with and that our customers have deployed on their own that accompany this type of service. But the fundamental concept here was, let's go back to that PID segment we showed instead of the provider of record, and let's use master patient indexing technology to compare the patient in the real-time message to each of these lists that have been preloaded or auto-created within the notification service. And when a match occurs, we'll trigger that outbound alert based on preferences that Rob will describe in a little more depth. So that's the fundamental and really important distinction that we want to make sure you all are seeing here. That we're not relying on the provider of record when notifying a PCP. We're not relying on the insurance segment when trying to notify a carrier. We're relying on patient identity and the comparison between the patient identity in the real-time message that's coming through the real-time ADT to the patient identity in each list. So just to, again, give you a quick sense of who's using it, it's a subset of some of those folks we showed on the first slide for the product that we've deployed. As Wendy said, we call it ENS, or the Encounter Notification Service. Rob's going to demo part of the user interface called Prompt. We typically route directly into products, but we do offer a UI into EHR products. Across our deployments in Florida and with partners in Delaware, Utah, and Maryland, throughout DC and in Philly, we have about 500, maybe over 500 subscribing organizations, meaning folks saying, here's my list of patients. Across those geographies, about 425 hospitals sending real-time ADTs, which results in about 750 notifications going out the door per month, with a whole range of different subscriber entity types. Again, with policy frameworks in place in each of those deployments that govern the rules of the road for being a subscriber. So with that, I'm going to turn it over to my colleague, Rob Horst here, and he's going to continue on.
Great. Thanks, Scott. Thanks, everyone, and thanks for joining us this afternoon. So this is a real high-level diagram just depicting sort of the data flow in our system. ENS, as Scott described, a core part of ENS is master patient indexing technology, and that really should be included in that center circle because it's a really critical part of it. But we try to deploy with an HIE's existing MPI technology. We also have the capability to deploy one ourselves, but it really is a key part. It's again what takes it's what matches the real-time message, the ADT messages coming in with the subscription lists that are being provided by the various stakeholders, whether they're ACOs or provider groups or insurance companies, et cetera. But if you start from left to right, we have hospitals, urgent care clinics, providers, or others providing the data inputs, and that includes ADTs. It can also include the CCDA document routing. We essentially look at the patient identity header in that CCDA document and route it exactly the same way that a notification would. Once those arrive in ENS, we compare the patient demographics in the ADT or in the CCDA with the subscription list that's been provided. And then we send those notifications off to the ENS recipients over there on the right. And of course, those are a range of different organizations such as skilled nursing facilities, payers, providers, and so forth. And as I'll talk about here on the next slide, we can receive those subscription lists in a number of different ways. So really, ENS relies on three core functions: patient attribution, one thing Scott mentioned is, that is subscribers providing their list to the E&S service, rather than us relying on the provider of record or insurance company to be accurately listed in the ADT that the patient is sort of self-identifying with at the registration event. So we rely on that patient attribution. Subscribers can provide their lists to the E&S service in a number of different ways. That could be via a flat file, like a CSV file. It could also be via a real-time ADT feed, and that's become a really popular method of what we call auto-subscribing. We can basically take the existing hospital feeds, and every time we see an A03 discharge event, we can automatically add that patient identity to a list, and then we can tell that hospital when patients they just discharged are being admitted somewhere else. So that's a really valuable method of attribution. The second core function is our notification preferences, and that's where a subscriber will define what they want to get. They might want to just receive notifications for ED admits. Maybe they want ED and inpatient admits. Maybe they just want discharges. They can really be flexible, and the E&S platform is really configurable in that way. Also, the frequency of notifications is important. Most organizations tend to get daily summary files, which includes a CSV file of the prior 24 hours worth of admits or discharges, and it's really a summary list that might get delivered to an organization via direct secure message or something like that. We also have the capability, though, to deliver them in real time. Interestingly and sort of amusingly, I think one of our first early implementations of this was with Johns Hopkins Community Physicians, and they elected to receive them all in real time. And when we turned that on initially, I think they were very quick to say, turn it off, because they were just getting flooded with real-time messages. Since that time, we've learned that really getting the daily summary lists is a much preferable way to do it. The list comes in typically at 6 a.m. and it gives a care manager an opportunity to open up that list and sort through it and find their highest risk patients, and then reach out and start coordinating care for those patients. Finally, on notification delivery, we have a number of different options here. Again, we can integrate with existing direct secure message platforms. Another popular method is to get them sent as an HL7 feed into an EHR. That really gets to workflow. I mean, if these messages are flowing into a system that you're already working within, that you're already familiar with, and you're not having to alt-tab and jump back and forth between different platforms, it really makes the whole process a lot easier. So we've been deploying HL7 feeds with more frequency lately. We can also connect via web service to various care management platforms. And then finally, we have the prompt web-based user interface, which is a standalone platform that receives these notifications, as well as some basic workflow tools to work through those notifications. And I'm going to jump into that application right now. Just give us 1 sec as we cut over to the prompt application. And as we log in here, we developed this recognizing that many organizations, many of the groups that are subscribing, might not have a direct secure messaging platform, might have a need for another application that they can work through. So as you log in the prompt, you can see it's set up very much like an email inbox. You have patient notifications up, and all the details of each of those notifications basically appearing on the right side. So I take this patient, Derek Cortez. These are all test patients, obviously, but as we take, I beg your pardon, Monte Ramirez we'll go to. So on the left here, you can see Monte Ramirez was admitted to Toronto General Hospital. You have the date. It was an ER admit, and you can come over here and see the relevant information about that hospitalization. So you see the most recent event here, the date, what type it was. You can, if diagnosis code or if reason for visit are included in the ADT message, we can provide that as well. Importantly here, we're also listing event history for these patients. So if there were prior notifications for a given patient, you'll see that here as well. And you can really begin to start to look at the history of an individual patient. And as you're reaching out and calling them, maybe you're having a conversation with Monte Ramirez and you're saying, hey, I see that you are also hospitalized on the 13th as well as on the 15th. it really gives a much more clear picture of that patient's history as you're reaching out and coordinating care. We also provide some very basic filtering technology that allow you to quickly get to frequent ER utilizers or frequent inpatient utilizers, as well as some basic search functionality. So these are really all important aspects of a notification service, and this is again our prompt web-based application. Jump back to the slides here. Go to the next one here. So stepping away for a few minutes from our ENS platform, we think it is important, and as Scott mentioned previously, we want to educate the audience today about what capabilities you should really be considering as you look at a notification platform. There are certainly a number of them out there, and we have some really relevant experience. We've seen a number of statewide HIEs deploy them in various manners, and really these next few slides are sort of our lessons learned coming out of the experiences that we've had working with some other organizations. That method of patient attribution is probably one of the most important. You want to get a subscription list that you define, and by you I mean I'm talking about the provider group, the ACO, the health plan. You know, getting the subscription list that is automated, that's based on the patient saying, hey, this is my doctor, is not necessarily the most reliable and useful to the provider that's receiving them. You know, a provider group might want just their highest risk patients. An ACO obviously has a defined list of patients that they want to control and they want to define. So that attribution is really critical. It also allows the organizations to refresh those lists periodically. In several of our implementations, you know, typically they're refreshing those lists weekly or at the most monthly to reflect their new patient population. Another point here is really the flexibility in subscription methods. That shouldn't be defined for you. You want to ask if they can, you might want to get them through a flat file so that you can receive it into a secure FTP folder and work them that way. You might want them sent through an interface directly into your electronic health record, as an example. You should also ask if there's a standalone platform. The capability to report on the event history or see admit and discharge trends, obviously very important there. You know, getting a notification today that your patient was hospitalized is certainly a very useful piece of information, but being able to look back and see where that patient has been and when, and possibly what for, is even more important. And you want to be able to pull out those trends and be able to have a more intelligent conversation with the patient, but also look across your population more broadly to understand what sort of trends are happening. The ability to deliver other payloads such as CCDAs, risk scores, or prior event histories. So if you think about an ENS type of platform, if you think back to the diagram that we displayed earlier, it's essentially the plumbing to make things happen. I mean, we are taking basic data that's flowing, and we're passing it around based on certain attributes. You know, notifications could carry a lot more with them. You know, our service, as Scott mentioned previously, delivers CCDA documents, but we've seen in other implementations, such as in Maine, Health InfoNet, they're able to deliver risk scores with their notifications as well. So it shouldn't just be a basic notification platform. You should make sure that the different payloads can be carried along with those notifications. Being able to look at analytics, being able to really look at what's happening with your subscribed patients over time is also very important. And then finally, having APIs to plug in with existing master patient index platforms, interface engines, et cetera, is very important. You don't want your platform to be that black box that you don't have a lot of control over, that you can't integrate with your existing technology stack, and so forth. Scott, let me just hand this back to you real quick just to talk about some of the other benefits of notifications more on the revenue side.
Sure, yeah. So there was actually a question that came through on hospital point of view that we'll circle back to in terms of value. What's the value case from a hospital? But one value case that we've seen as really important to ambulatory providers in the community are the CMS Transitional Care Management CPT codes, which essentially permit billing based on a few post-discharge activities. One is calling the patient within 48 hours of being discharged, which without notification service is really difficult to do. Two is you've got to get them into the office for a face-to-face visit, and then three, they can't be readmitted. But if you can accomplish those things all from the spark of the notification, there's an opportunity to bill for those codes. And this is the good kind of fee-for-service, right? It's incentivizing care that, as Rob will show in a few slides, really does have an impact on readmission rates and better outcomes for patients. So other commercial carriers are starting to adopt these TCM type codes in different geographies around the country, but what we found is valuable is to just kind of highlight for participants in the community that may be interested in participating what that opportunity looks like. So we created a little calculator here, and you can see, you can pick, enter the number of Medicare beneficiaries, or if you happen to operate in a jurisdiction where some of your commercial carriers offer a similar fee, you can put in the appropriate number there, pick your state. We used the Dartmouth Atlas Medicare discharge rate. And then we did a method where we took the difference between a visit with a TCM code tied to it and one that is just a regular office visit. And it comes out to an average difference of roughly $71. And then the capture rate is how frequently can you actually execute on all three of those things and actually bill for the code, and we come up with a projected revenue. And it's been helpful as a tool to help folks see the opportunity and justify engagement. So I'll also touch on this one. So in Maryland, we did a little research into how effectively are we notifying providers in the communities about discharges at a population level. This cut is at a statewide level for Medicare beneficiaries, but we also looked at it by county, by zip code, by individual hospital, and effectively what we're showing here in the Q1 of 2015 is for all Medicare inpatient discharges from Maryland hospitals, the top line, the 29, almost 30,000, how frequently did we have at least one type of notification, meaning an ER registration event, an inpatient admission, inpatient discharge? How frequently did we have a notification going to a provider in the community? So we excluded carriers in this particular study, and it's about 50% of the time, or 15,000 notifications out of those 30, we could match up with an actual discharge. And then when we looked at what about a specific discharge notification, tying back to that TCM fee, it's still pretty high, just shy of 50%. And so this is an example of some of the basic insight you can start to get, but really valuable insight to be able to understand how well a deployment in a community, whether it's through a health information exchange or not, is being adopted. And lastly, this is just an example overall, so we're going to step back out of just the Medicare population and look at ENS more broadly. In Maryland, the service has grown steadily but quickly over time, with about just north of 700,000 notifications per month being triggered out to participants throughout the state.
Great, thanks, Scott. So I'm just going to touch on some of the other clinical benefits of notifications, and these were really taken from a webinar that we did in combination with Johns Hopkins community physicians this time last year. And really, and this is directly from them. They've been strong advocates of using the use of notifications as a really valuable care coordination tool. But improved communication, obviously key. I mean, getting that notification, knowing that something happened, is really valuable. It allows the PCP or care manager to immediately follow up with the patient and coordinate care, make sure that they're adhering to their medications, making sure that they have a care plan in place. Those types of activities can all be triggered off of these events. Quality improvement, it obviously improves follow-up calls, the timeliness of those follow-up calls, as well as the visits with a patient's PCP. And the slide I'll show you next here really highlights that. And then readmission rates are lower. Johns Hopkins Community Physicians, again, has found that patients seen in 7 days compared to those not, or patients, I beg your pardon, patients seen in 7 days have a lower readmission rate to those that they did not receive notification for. And on this next slide, you can see, let's see here. Here we go. I just pulled out a few of these numbers here, but if you look at the comparison, the middle column here, this is the readmission rate of patients that had been seen by their PCP in 7 days, meaning that they had gotten a notification from CRISP. And over here on the right column are those that did not. And as you can see, there's a pretty large gap between those numbers. So Hopkins has really found it to be a very valuable tool to help get those numbers down. So I'm just going to jump over to another one of our deployments and some of the success stories they've had as well. So this is for the Utah Health Information Network, or UHIN. They have a number of subscribing entities that are doing some really innovative things. Molina Healthcare is a Medicaid MCO operating in Utah, and they wanted to be notified when their identified asthma patients were being admitted or discharged from an ED. So they provide a list of those patients that they obviously know about to UHIN. UHIN loads that into the ENS service, and then if those patients get hospitalized in an ED in Utah, they get a notification. They can then quickly follow up with those patients to make sure that they have a care plan, that they're managing their medications, and hopefully keep them out of future ED visits. They're also using this really as a customer satisfaction tool in one way. They want to make sure that new mothers are getting postpartum visits scheduled. So they are able to identify when there are inpatient visits occurring for delivery. They then reach out to the new moms and they're able to schedule, make sure that they get their postpartum visit, say congratulations on your newborn, and really get people into the office faster after they've delivered. Finally, for Valley Behavioral Health, they wanted to get notified when their high-risk patients are being admitted and in an inpatient or ED setting, so they can intervene in care. Again, they just provide the list of their patients to UHIN, and UHIN's loading them in and providing those notifications. So those are just some examples, and with that, I think we're going to jump to some questions here.
Yeah, so I'll take the first one here, and folks, feel free to ask any level of question you want. We'll be super honest with you with our experience and kind of what we see, what works, what doesn't work, and try to dig in with you. So let me just touch on the first. So help me understand the point of view from a hospital. Is it the fear of net loss of revenue? And then the second part of that question is the hospital ADT feed typically made available to the entire community, just a subset of partners like an HIE. So let me kind of parse that one apart. So in the first part, I think there's a range of motivating factors for the hospital side participation, really the source of the ADTs. Whether that's because there is a health information exchange in the community and those ADTs are already flowing and you can essentially supplement the HIE with this value-add service, or if you're standing up a network, value-based payment is rapidly approaching. It's obviously already a percentage of the hospital reimbursement mix, but with the CMS goals for Medicare by 2018 to hit 50% value-based payment, that's going to motivate population health management and care coordination activities with providers in the community. And to the extent hospitals do have a revenue-based objective to coordinate care with those providers in the community, this is a relatively low barrier service to enable that kind of engagement. The second part is the ADT feed typically made available to the entire community. So it depends on the entity that's operating in the geography. If there is a kind of multi-stakeholder governed health information exchange, then that tends to be an appropriate pathway to enable a service like this. It's not the only pathway. Typically, a hospital will make their ADT available based on some specific permitted purposes and some expressly prohibited purposes, and that's an important aspect of the trust relationship and defining what's allowed and what's not allowed in a service like this, and starting with a relatively constrained approach, I think is rational. We will use, for example, ADTs from your facility only to notify providers or carriers in the community with these circumstances, right? That it's an active patient of the practice, that it's an active member of the carrier things along those lines. Rob, do you want to pick from the basket?
Sure. There's a question here. The comment, and as well as a comment. This is a great solution to take care of patients, but how do you deal with the issue of getting everyone connected? That's a big effort, and that's a great question. We've seen some early success with several statewide health information exchanges, such as CRISP or DIN. They obviously had quite a bit of connectivity coming into this. And as a matter of fact, I mean, they had all of their hospitals connected before they started using the ENS service. There are other organizations, though, that were, other statewide HIEs or regional HIEs that were not necessarily funded out of high-tech, such as the Health Share Information Exchange in southeastern Pennsylvania. This is another one of our customers that has recently gone live and got 42 hospitals in the Philadelphia region connected very rapidly. And their first service out of the gate was ENS. They've been very successful in rolling that out since they've gone live. So it doesn't, I think the thing that's really neat about Health Share, or HSX as we sometimes refer to them as, is that they really saw that they could get rapid value by taking advantage of the ADTs first, rather than focusing on the longer term goals of getting a query portal in place, which is undoubtedly a very valuable service, but they recognized that they could get the ADTs done very quickly, to get a valuable service out of the door very quickly, and so that's what they pursued. So sort of a long answer, but I think it's important to recognize that health information exchanges, whether they be regional or sort of a statewide entity, can really rapidly get these types of services deployed because ADTs are very easy to deploy.
I'd just highlight one other scenario there, because we've got our colleagues in Florida on, which is how quickly the Florida HIE established over 200 ADT connections. It was about 5.5 months from start to finish, and so that just kind of demonstrates that with the right motivation and partnerships, you can move really, really quickly on these kinds of things. So let's see here. Try to find one that's tactical here. So I will pick, well, how well is the industry prepared from a process perspective to take advantage and utilize a tool like this? That's actually a great question that we kind of had thoughts on as we entered this space, but have learned a lot over the years in terms of a range of different carrier types. But think about insurance carriers, MCOs, and then think about practices. When we started sending notifications, Rob mentioned with our partners at JHCP sending real-time alerts, there weren't established processes to receive that alert in clinical workflow processes and then engage the patient to get them into the office. And so JHCP did a lot of really great work to define that. But for smaller practices that maybe don't have the infrastructure of a large health system or a large practice, the kind of practice transformation support and clinical workflow support to establish processes to engage with the patient, to track whether or not they came in, to understand how to bill for the transitional care management fees is a really important aspect of deploying the service. It is a big misstep to make the assumption that just by virtue of sending the alert, you're going to get a positive outcome. We certainly see variation, and I think our customers that have deployed the service see variation in how effectively certain practices are able to use the notifications over other practices that may not have, again, that support or infrastructure to be able to engage the patient in a proactive way following the discharge.
And just to add on to that, I think workflow is another big part of that practice transformation, and really is why we've adapted our methods of delivering notifications to various organizations based on their needs. The need for receiving notifications via an HL7 feed was really coming from a customer that said, hey, we don't want to go to another system. We don't want to remember another username or password to go access our notifications. Can you send them into the system that we're already using? And so that was really the impetus for doing that. So I think flexibility in how you receive the notifications so that they can best fit the workflow is another key aspect of it. Another question came in here, are you a HISP or are you HISP agnostic? We are, as AI, our product is HISP agnostic. We are not a HISP. We've worked with 2 or 3 to date. As long as there's an API that we can connect with, we have the capability to deliver notifications through the HISP.
So another question here. Who are the typical and most successful funders to establish feeds and for covering maintenance costs? So another great question. So varies widely based on who is deploying and operating the notification service. There are certainly the models a lot of you all may be familiar with, in which the federal government through high tech or state governments have made investments and kind of provided seed capital to establish these kinds of platforms within a geography or a state. And so that certainly helps. There are different fee structures, both charging participation fees to hospitals, to carriers, in some cases to practices, and it helps to tie any practice fee back to, are they able to bill for the TCM codes and show that there's a net new revenue opportunity associated with the fee that's being incurred as part of participation in a service like this. But putting funding from a grant-making source aside, state, federal, private aside, there are kind of starting with zero approaches to getting this done in terms of taking on some risk depending on who the entity is deploying. As AI, we contemplate the ability to be able to deploy out of the gates and help our partners establish the network and really get from zero to value very quickly so that net new revenue can be created to support the service. And so there are some models independent of grant funding to get a service like this stood up.
Great. Another question here, are there more use cases available that my CMO or CTO could look at? Yeah, we actually do have a few documents available for download as part of the GoToMeeting. They should be available as links on the right side of your screen, and you can pull those down and review them. We go into a little more detail about the product as well as some of the really interesting uses that a few of our statewide implementations have implemented over the past couple of years. How can ACOs use these notifications? That's a great question. There's probably a number of different ways to answer, so maybe I can get some support from Scott over here as well. But ACOs, they obviously have a cohort of patients that they're following. That part is easy. I mean, providing that list of patients to the ENS organization that's in your state and having them provide you the notifications is obviously critical. I think in a lot of cases the ACO is receiving the notifications and then they have a litany of workflows that take place after that to coordinate care. I mean, Scott.
Yeah, just think about this one for a second in terms of an ACO operating in a community in which their members may go to multiple hospitals. Even a single hospital, this still applies. I mean, if you've got, say 3,000 members in your ACO, how are you going to know when they arrive at the hospital? What's the process to actually know about and then engage that patient, both on the front end and during the hospitalization and certainly post-discharge? And what we see is in some places that lack a solution like this, that ACO kind of directly approaching the hospital and saying, let me know if any of these people arrive, because the patient isn't showing up in most places saying, this is my ACO, right? And so absent a solution like this, it is really difficult, and if it is possible, it's very patchy to have a clear sense of when patients are arriving. We did another little kind of study on a ACO we work with here in Maryland to look at how frequently, when we compared to the claims data they received from Medicare, the CCLF file, how frequently did we get a notification to them for an actual discharge, kind of looking back in time. And for a 2-month period of time, it's about 99% of the time we accurately made that match and got them the alert. Now that's dependent on each geography's approach to tuning, and that's what we facilitate of the master patient indexing process. That's really part of, again, that secret sauce of how this works. But again, it's really critical for an ACO or anyone managing a population to be able to effectively identify when their members or patients are arriving at a hospital.
Great. Thanks, Scott. We got a question on pricing. We price our solution on a per member per month basis, and obviously would be happy to dig into that a little bit more if folks wish to follow up with us on that. But I think that's important, that it's, you know, we're pricing based on the number of subscribed to lives, if that makes sense. So if you provide us with a panel of 1,000 patients, you're going to pay for those 1,000 patients. You're not going to pay for numerous transactions. There's not a per transaction fee that's going on here. So and that's worked pretty well for our customers to date.
Yeah, and maybe, let's see here, what kind of challenges did you face when training individuals to review the data set? So this kind of alludes back to a little bit of the workflow challenges, particularly for smaller practices or folks that weren't used to receiving this kind of information. And there were both kind of team-based approaches. Some practices hired net new employees to actually manage this process for some of the larger practices. But just one good example was, you know, as Rob talked about earlier in the slides, we can send either real-time alerts or daily summaries or you know, a summary every 3 hours. And one practice developed a team-based approach where they had a 7:30 a.m. kind of stand-up meeting, and they reviewed the panel that they received that morning, and then assigned individuals within it to nurses within the practice to do outreach and scheduling to get those patients in the door. A lot of folks will prioritize their Medicare beneficiaries and make sure they're calling them first. What we found is that most practices engage on the full panel on a daily basis, but it's really at that workflow level where serious attention needs to be paid.
Great. I think that probably concludes our questions today.
Yeah.
We just want to thank everybody for attending. Again, we have our contact information up here on the slide that's on the screen currently. Feel free to reach out to either Scott or me, and we'll be happy to follow up with you if you have any other questions. We also have a few documents available for download. Please be able to take advantage of those, and you can visit us on our website at ainq.com. This webinar is also being recorded, and we'll make this available on our website at the conclusion